So we have a lot of coverage of cardiovascular topics, but we're going to get a really nice overview of some of the high yield topics for the test over the next hour. Dr. Kira, I will turn it over to you. Thank you.
Right. I'm Kavita. I'm one of the cardiologists here at the VA. And so I'll go over some board review questions. I recently had access to the MixApp question bank, so I went through them. So these questions are updated and I think fairly reflective of the questions that I saw in the MixApp. So case one, we have a 62-year-old male who presents to the ED with severe chest pain with radiation to the back. On physical exam, his blood pressure is 170 over 65 on the right arm and 130 over 60 on the left arm. Pulse is 110 beats a minute and oxygen sat is 90% on room air. There's a 3 out of 6 diastolic murmur on the left sternal border, and the ECG shows sinus tachycardia with some ST depressions. What diagnostic test should be ordered next? Should it be A, a coronary angiogram, B, a transesophageal echocardiogram only, or C, a CT angiogram of the chest only? So this actually was pretty similar to a question that was on MixApp. I also thought it was a bit tricky. And I think it's important on the exam, if they're giving you murmurs, to really pay attention to why those are there. There's a lot of murmurs on the exam that can kind of make you confused, I think, but important to know. All right, so the polls are coming in with most people saying C, and then a few people saying A. In the interest of time, I'll just kind of proceed. So actually, no one got it right. It was B, which also I thought was sort of tricky when I looked at this question. And the real key reason is because I said only. So this question is basically setting you up for someone who's having an aortic dissection because you have the discrepant blood pressures on the different arms. But the murmur is important because it's probably an ascending aortic dissection that's affecting the aortic valve and causing aortic regurgitation. So if you do a coronary angiogram, you can perpetuate that dissection, right? So this is not setting you up for sort of an ACS presentation where you would do a coronary angiogram. If you just do a CT angiogram of the chest, yes, you're going to diagnose the aortic dissection, but you're going to miss any valvular disease. So really the answer is if you have to do just one study, it would be a transesophageal echocardiogram because that would allow you to see the ascending aortic dissection as well as characterize the aortic regurgitation, and that's going to have surgical implications. Now, in real life, what's going to happen? Probably the patient's going to get a CT angiogram of the chest and an echo and then go to surgery, right? Or a TE intraoperatively. But for the sake of the test, this was a real question, and that's kind of what the answer was. So I think just basically know that an aortic dissection, if they're also including a diastolic murmur, you have to consider that there's significant aortic regurgitation and involvement of the aortic valve. All right, so case number 2. A 68-year-old with a past medical history of hypertension and known severe aortic regurgitation follows up in clinic after routine transthoracic echocardiogram. The patient is asymptomatic with good exercise capacity. On exam, he has a 3 out of 6 holosystolic murmur at the left sternal border and a 2 out of 6 systolic murmur at the right upper sternal border. The transthoracic echocardiogram shows an LVEF of 50% with severe aortic regurgitation and a dilated left ventricle with the left ventricular end systolic diameter of 55 millimeters mercury. What is the next best step in management? Is it A, refer for surgical valve replacement? Is it B, refer for TAVR? Is it C, repeat a transthoracic echocardiogram in 6 months, given he is asymptomatic? And I do apologize on this question, Sem, that the first murmur should be a holodiastolic murmur. I apologize about that. All right, so looks like we have 6 responses, and they're pretty much split between all of the answers. So the answer is A, refer the patient for a surgical valve replacement. So um, in aortic regurgitation, as with mitral regurgitation as well, the main kind of changes to the LV that occur with a regurgitant lesion, because it's a volume load to the LV, is that you get LV dilation, and then eventually you will get reduction in LV systolic function too. And so certainly if the patient is symptomatic, you're going to refer them for valve replacement. But in asymptomatic severe aortic regurgitation patients, the things that we look at is signs of that LV remodeling. So reduction in EF and dilation. And so if the patient starts to have those remodeling already, then you want to refer these patients for valve replacement, because after their valve replacement for a regurgitant lesion, their EF is actually going to get worse because you're going to increase the afterload to the heart. So the goal is to have them go from a hyperdynamic EF to a normal EF, not to go from already a low EF to a lower EF. So you really want to catch these patients before that dilation occurs. That's why in severe AR and severe MR patients, we're getting echoes every 6 months to a year to see any signs of dilation, reduction in EF, and that's when we have to refer them for surgery, even if they don't have symptoms. And the answer between either surgical versus TAVR. So TAVR is not utilized for aortic regurgitation. It really requires that calcific stenosis to anchor that TAVR valve. There are some off-use labeling of TAVR for AR, but it's certainly not the standard of care. So this is the type of patient that definitely should have surgical valve replacement. Here are the guidelines from the ACC valve guidelines. So basically, as I mentioned, if they have severe AR and they're symptomatic, yes, class 1 indication for aortic valve replacement. If they're asymptomatic and they start to have their EF drop, if they start to have their LV systolic diameter increasing, then surgery is also indicated for these patients. And these guidelines are pretty similar for aortic, primary mitral regurgitation, with slightly different cutoffs for EF and LV dysfunction or dilation. Okay, so what is causing the 2 out of 6 systolic murmur at the right upper sternal border? All right, so it looks like we have a fair amount of responses, and most people are saying C, and that is the answer. So the diastolic murmur, of course, is the aortic regurgitation itself, but because you have that extra volume coming back into the LV and diastole and systole, you also have high forward stroke volume, and so you get that flow murmur. All right, case 3. We have a 75-year-old male with a past medical history of coronary artery disease, status post-CABG, heart failure with a reduced ejection fraction of 30%, hypertension, hyperlipidemia, diabetes, who presents to clinic for follow-up after a resubmission for heart failure. Medications include carvedilol, 3.125 BID, lisinopril 40 milligrams daily, spironolactone 25 milligrams daily, and empagliflozin 10 milligrams daily, and Lasix 20 milligrams BID. Vitals in clinic show a heart rate of 55 beats a minute and a blood pressure of 145/80. On exam, his JVD is normal. He has normal renal function and potassium on recent labs. What medication change do you recommend? Is it A, stop lisinopril and start sacubitril valsartan 49/51 the following day? Is it B, stop lisinopril and start sacubitril valsartan after 36 hours? Is it C, stop lisinopril and start losartan 100 milligrams a day? Or is it D, increase furosemide to 40 milligrams BID? So most people said B, which is the correct answer. So, so far the questions have been kind of very testy, but this is actually pretty practical and something that you certainly would see in everyday practice. And so this question is based on the Paradigm HF trial, which looked at ARNIs versus ACE inhibitors in patients with HFrEF. And it was a positive trial and showing that there was a significant difference in the primary composite endpoint, as well as the individual endpoints of death from cardiovascular cause and death from any cause, comparing the Entresto to an ACE inhibitor in this patient population. So as a result, it is a class 1 indication by the guidelines in patients with HFrEF and NYHA class 2 or 3 to use an ARNI, and if they're on an ACE or an ARB, to actually switch them. And in terms of how you switch them, I think this might be a little bit blurry, but if they're on an ARB already, you can just switch them. And you kind of decide your starting dose based on the starting dose of their ARB. So if they're on a high dose of an ARB already, you would start them on Entresto 4951. If they're on a low dose of an ARB, then you would start with 2426 and kind of up titrate. But if they are on an ACE inhibitor, because of the concomitant neprilysin inhibitor, you actually have to have a washout of the ACE inhibitor for 36 hours. And then pretty much the same in terms of dosing. If they're on a high dose versus low dose ACE, what starting dose of Entresto you'll put the patients on. So again, a very practical question. So 2 weeks later in follow-up, the patient has a stable chemistry panel. Blood pressure is 135/80. What is the next best step in management? All right, so we have most people putting A as the answer, which is the correct answer. So you would up titrate the patient to max dose of Entresto. So it's important to recognize in heart failure, GDMT, we really want to optimize these patients to be on the max tolerated dose of GDMT. Okay, so same patient, a repeat echocardiogram in 4 months shows that the EF remains 30%. Patient is feeling well and reports improved exercise tolerance. The ECG is below. What is the next best step in management? Would you A, refer for a single chamber defibrillator, B, refer for a biventricular pacer and defibrillator, or C, refer for a transplant evaluation? All right, so most people are saying B, which is in fact the answer. So as you identified, after a reasonable amount of GDMT with this patient, the EF still remains less than 30 to 35%. And so a defibrillator is indicated, but I also included this ECG, which shows a left bundle branch block. And so because of the left bundle branch block, the patient would be qualified for what we call CRT, or cardiac resynchronization therapy, which actually helps to treat that dysynchrony and narrow the left bundle branch in the QRS complex, which is biventricular pacing. Okay, case 3. I have a 68-year-old male with a past medical history of hypertension, hyperlipidemia, prior tobacco use, COPD, who presents for chest pain. The pain is described as chest pressure lasting for a few minutes at rest. It does not appear to be worsened with exertion. His ECG is shown below. He reports that he goes on daily walks for exercise and will experience shortness of breath, but not chest pain. On exam, he has significant end expiratory wheezes. His most recent lipid panel shows an LDL of 100 and his ASCVD risk score is 25%. He is hesitant to start a statin. What is the next best step in management? Is it A, an exercise treadmill stress test? Is it B, a myocardial perfusion test with pharmacologic stress? Is it C, a CT coronary angiogram? Or is it D, no testing is indicated? All right, so looks like the most people said B, and then some people saying C. And the answer is, in fact, C. So, this question points out a few things. So you have someone who's, intermediate risk. The chest pain is not exertional, but they certainly have a ton of risk factors. So some sort of stress test is indicated, or some sort of risk stratification, I would say. The ECG shows a left bundle branch block. And so with the left bundle branch block, just a plain old exercise treadmill stress test without imaging would not be appropriate. It's contraindicated if you have a left bundle branch block because you can't interpret the STs alone. You would need some sort of imaging. So if it was a stress echo, a treadmill stress echo, that would potentially be reasonable if we think the patient could exert himself enough. The reason that a myocardial perfusion with pharmacologic stress is not indicated is because I specifically wrote that the patient has significant end expiratory wheezes. So, usually the stress agent that's given is rigadenosine, which can cause bronchospasm. So it's also contraindicated in patients that have wheezing. But also what I put in here and I added for a specific reason is that the patient has a high ASCVD risk score, but doesn't want to stay on a statin, doesn't want to be on a statin. So the CT coronary angio gives you sort of extra information that a stress test wouldn't. So for example, a negative stress test, a negative NPS study would just tell you that their symptoms probably are not anginal or related to obstructive coronary disease, but it doesn't actually tell you should they be on a statin or not, or it, that they should be on a statin, but the patient doesn't want to be on one, for example, based on risk score. But the CT coronary angio gives you added information that this patient has a calcium score of X, Y, Z. This is the percent narrowing. And so that can be used to add to the conversation for their indication for a statin, as well as potential LDL targets. So this is just kind of basically a summary of everything that I just said. And so to kind of follow up on this question, so again, I think this is a pretty practical question that you might be ordering these tests and getting these results. So now let's say the CT coronary angiogram reveals a calcium score of 500 Aganson's units with non-obstructive disease. The maximal luminal narrowing is only 25 to 40% that is seen in multiple vessels. There's no left main disease. His blood pressure is consistently 145/90. What is the next best step in management? Is it A, recommend initiation of a low intensity statin therapy? B, recommend initiation of a moderate intensity statin? C, recommend initiation of antihypertensive therapy. D, recommend invasive coronary angiogram. Or E, B, and C. All right, so looks like the majority of people said E, which is the right answer. I think it's always a good test kind of skill to, if they say B and C, A and D, to kind of choose that. But essentially, this is kind of the value of the the coronary CT angiogram, is that it shows the patient that, probably your symptoms aren't related to your coronary disease because the percent luminal narrowing is low, but you do have coronary disease. And so this adds to the conversation of statin use. And so it is even a stronger indication now from the provider to have this shared decision making with the patient to more strongly now recommend moderate to high intensity statin, and then also to recommend better other risk factor modifications such as blood pressure lowering therapy. So the new ACC lipid guidelines came out just this year. I'm not sure how likely these exact details are not going to be on the board review just because they're too new of guidelines, but I think it's still good for everyone to kind of know. And I think that what the more recent lipid guidelines adds to what the other guidelines show is actual now targets for LDL lowering, like what should the target LDL be, not just 30% reduction, et cetera, but also what do we do with these patients with subclinical atherosclerosis and certain CAC scores, et cetera. And it actually has these guidelines. So our patient had severe CAC that was at 500. And so the guidelines actually recommend lowering the LDL less than 70. So it's actually pretty specific, an option to get it even less than 55. So I think this is a really great part of the new guidelines, is that we actually have targets for a lot of different things. So this is, I think, probably one of the best summary tables in those guidelines is basically, should your target LDL be 100? Should it be less than 70 or less than 55? And based on these different patient factors. And so this also includes, do they have diabetes? Do they have this subclinical atherosclerosis, clinical ASCVD, and then primary prevention based on their ASCVD risk score? Is it greater than 10%? Then it should be less than 70. So I think this is really helpful. And like I said, if I were to pick one kind of table in the guidelines, this is what I would say. Now, again, I don't think these targets will not be on the next board review, but just for practical knowledge and understanding. Also, the second table in the guidelines that I think is the best is, in some of these for clinical ASCVD, our indication to get them less than 55 is if they're very high risk. What does very high risk mean? Well, this is what it means. So they have to have greater than 2 major ASCVD events or 1 major and 2 high risk features. So for a lot of my patients, they're going to be at very high risk, but for primary care, et cetera, they may not be. So this is just also a very helpful table. So if I had to pick 2 tables, these are the 2 that I reference the most in the new guidelines. I thought I would just stop there to see if there's questions, because I know that the leading to lipid guidelines have generated a lot of conversation. So wanted to just see if there's any questions. I haven't been checking the chat.
Yes, there is a question from Andrew.
Mm-hmm.
And Andrew is, I think, a nuanced question. They say that they remember reading that the CCTA algorithms aren't really accurate identifying an intraluminal occlusion specifically. And with that high AU score, would there be a reason to think about doing an angiogram given the moderate risk?
Yeah. So, the CCTAs are with contrast, right? The calcium scores are without contrast. So the CCTAs actually should give you pretty good estimation of luminal narrowing. Now, certainly they're not always accurate, and at every kind of facility there might be differences. I would say at our facility, for example, the CCTAs tend to overcall the percent narrowing when we go and cath these patients. But I would say that in this patient, I would probably focus on risk factor modification mostly. And then, you could, if they could continue to have persistent symptoms that you're worried about, yeah, you can always do a coronary angiogram. But especially with these stenoses being reported as, I think I said 25 to 40%, that's pretty non-obstructive. So yeah, I think that the percent luminal narrowing, again, it depends on what facilities you're at and the quality of your studies. They tend to be pretty good. One thing to note is that in a calcium score, for example, is not good to detect soft plaques. So if you're only getting a calcium score in your patient, you really shouldn't be getting a calcium score in young patients, especially, let's say, like a 40-year-old with severe hyperlipidemia. They tend to have soft plaques, and the calcium scores only look at hard plaques. And so these patients with severe hyperlipidemia who are young might have soft plaques with luminal narrowing, but no calcification. So their calcium score might be normal or very low. But when you add the CT coronary angiogram part of it with the contrast, you actually are seeing the percent luminal narrowings. And like I said, I think in our facility, at least, they tend to overcall the percent narrowing. So if they're already calling it non-obstructive, it's usually pretty non-obstructive. Any other questions? I think in ours, the undercall, which is where my confusion. Yeah. That, I think that is reasonable to consider. But the other things that we really look at is, is there left main disease? So, in this patient, I think that he had disease in all 3 vessels. But let's say the report showed only single vessel disease, RCA lesion that was, maybe it was even severe. really based on the ischemia guidelines, it wouldn't be an indication for cath to begin with. It would really be risk factor modification first, anti-anginal therapy if you think it's angina that's causing their symptoms, and you would only go to revascularization if they have progressive symptoms. And so in this question, I said that they don't have left main disease. So left main disease is one of those things where there probably potentially is a mortality benefit to revascularization even without symptoms, for example. So I think that's sort of the piece of it, is that the CT coronary can kind of exclude very severe high risk lesions. It might show some single vessel low risk lesions, but at the end of the day, really risk factor modification is the first thing that we want to do. I think I might have a question that kind of goes along with that too. Okay, so I'll move on to the next question, but feel free to ask any other questions. I just pulled up the Q&A box, so I'll try to manage that or look at that more. Okay, so you have a 73-year-old female who presents for follow-up after an admission for heart failure exacerbation. This is her third admission this year. Her echocardiogram shows a normal LVEF of 65 with stage 2 diastolic dysfunction with elevated left atrial pressures and an intermediate right atrial pressure of 8 millimeters mercury. Her vitals show a BP of 120/75, a heart rate of 80, and her recent labs show normal creatinine and a potassium of 4.3. She is not a diabetic. She is currently taking losartan 100 milligrams daily and Lasix 80 milligrams BID. On exam, she appears just mildly volume up. What additional medications would you recommend adding? Would you recommend metoprolol succinate 25 daily? B, spironolactone 12.5 milligrams daily? C, empagliflozin 12.5 milligrams daily? D, both B and C, or E, metolazone 2.5 milligrams daily? All right, so it looks like most people said C, most people said C, but a fair amount said D. So the answer is D. The patient has HFpEF, and so these are the heart failure guidelines from 2023. And it really puts SGLT2 inhibitors as the kind of class 2A recommendation for HFpEF, and then ARNIs are MRAs and ARBs as class 2B recommendations for HFpEF. And the reason that the distinction between the 2A recommendation, which is a higher level of recommendation, versus a 2B, is that the SGLT2 clinical trials were positive trials, meaning that the primary composite endpoint was positive. But if you look at the actual the data, it's still all driven by heart failure hospitalizations, not by mortality, which is what we see in the MRA trials, is that unfortunately, the overall primary composite endpoint was negative, and that's why it's a 2B recommendation, but there was a significant reduction in hospitalization. So that's why it gets a lower level of evidence. But when I think about these medications, I pretty much think about them as pretty much the same, is that they reduce hospitalizations. So in patients who have evidence of volume overload with HFpEF, I usually put them on both of these agents. It wouldn't be wrong to start with one and then do the other later. And then usually my goal ultimately is, with the addition of these two kind of weak diuretic medications, would be to kind of reduce their loop diuretic. Because as we know, the loop diuretics don't really improve overall mortality. They're really kind of just treating the volume and the symptoms. Whereas the SGLT2 inhibitors, MRAs, might actually have potential for cardiac remodeling. And then also renal protection. So usually I try to add both of these agents, especially for someone who's already hypervolemic, with the goal of trying to decrease their loop diuretic as best as I can. Okay, next case, you have a 50-year-old male who presents with exertional dyspnea and chest pressure. He has no significant past medical history. On exam, he is noted to have an irregular murmur. He also has a 3 out of 6 crescendo, decrescendo systolic murmur at the left lower sternal border. When squatting, the murmur decreases in intensity, And when standing, the murmur increases in intensity. With hand grip, the murmur decreases in intensity. The blood pressure is 126/80 and the heart rate is 90. What is the most likely diagnosis in this patient? Is it A, a bicuspid aortic valve with stenosis? Is it B, hypertensive cardiomyopathy? Is it C, tachycardia-mediated cardiomyopathy? Or is it D, pulmonic stenosis? All right, so looks like most people said B, which is the answer. So what this question really is testing is your understanding of murmurs between A and B, essentially. Is it aortic stenosis or is it dynamic LVOT obstruction? And so the murmurs are very important to kind of understand. So I'm just going to go through pathophysiology a little bit. So in hypertrophic cardiomyopathy, you get LVOT obstruction for a few different reasons. Number one is that interventricular septum is thickened, kind of narrows that LVOT, creates this flow acceleration through the LVOT. And then that flow acceleration can cause that anterior mitral leaflet, which is shown here, to kind of be sucked up into the LVOT. And also, patients with hypertrophic cardiomyopathy tend to have abnormal mitral valves. They're born oftentimes with apically displaced papillary muscles that affects their mitral valve. So they inherently have sort of an abnormal mitral valve that kind of puts them vulnerable to these what we call venturi forces, which is that flow acceleration that kind of sucks that anterior leaflet. And that's what we call SAM, or systolic anterior motion of the mitral valve. So that further causes that obstruction. It can also cause then mitral regurgitation, which you're seeing here in this picture. And so the key with aortic stenosis versus hypertrophic cardiomyopathy is that aortic stenosis is a fixed obstruction. The valve is narrow and it's going to stay narrow regardless of your volume status and your loading conditions. Whereas hypertrophic cardiomyopathy, the obstruction is dynamic. It can come and go. With medical treatment, with changes in volume status, et cetera, the obstruction can kind of increase, decrease, come and go. And so it's worse. The amount of the obstruction is worse if a patient has a smaller cavity. So these are kind of the things, the maneuvers that you can do. So if the patient, basically anything that increases their preload, so fills up that LV, so squatting, leg raise, that all increases your preload and gives more blood to the LV. That's going to decrease your HCM murmur because now you're filled up a little bit more and you're less likely to have that LVOT obstruction. But in aortic stenosis, that valve is tight and it's going to stay tight. And so the increased preload just makes more blood flow going through this fixed obstruction. So it's going to increase the murmur. Anything that decreases the preload, so standing, Valsalva, that's going to increase the HCM murmur and decrease the AS murmur. So in HCM patients, for example, when we're doing an echocardiogram, or even when I listen to them, I always have them Valsalva, and we have them Valsalva with echo because we want to see if their LVOT obstruction worsens with Valsalva. And then hand grip increases afterload, so it actually kind of decreases both of the murmurs. So this is something that certainly will get tested, is basically understanding of murmurs. So I see a question coming in about the last question, so I'll just kind of go back. Let's see. Yeah, so in terms of kind of EF cutoffs for HFpEF versus HFmrEF, still the guidelines really are that HFpEF is EF greater than or equal to 50%, and then HFrEF is EF less than 40%. So basically anything between 40 and 50 is HFmrEF. So you see probably a lot of echoes that's 40 to 45% or 45 to 50%. That would technically be HF mid-range EF. The reason that the guidelines are different between men and women is because specifically for example, the Paragon HF trial, which looked at ARNIs in HFpEF/HFmrEF. That was a negative trial that didn't show any benefit, but there was a trend towards benefit in women specifically for ARNIs and people on that HEF more mid-range, lower EF side of things. And so that's kind of why those guidelines come in. Yes, so that's kind of specifically why those guidelines have come in, just based on the cutoffs from the trials, but not necessarily the guidelines. The absolute cutoffs for EF for mid-range versus HFpEF, like I said, is 40 to 50 will be HFmrEF. But these cutoffs are kind of based on the clinical trials that showed that. All right, let's see. Okay, next case. So an 81-year-old female with a past medical history of coronary artery disease with a prior CABG 5 years ago, hypertension, hyperlipidemia, CKD, presents to clinic complaining of palpitations. EKG is shown below. The patient is currently taking aspirin 81 milligrams daily, atorvastatin 80 milligrams daily, and amlodipine 10 milligrams daily. The creatinine is 1.8. What is the next best step in management? Is it A, start Eliquis 5 milligrams BID? Is it B, start Eliquis 2.5 milligrams BID? Is it C, stop aspirin? Is it D, A and C, or E, B and C? All right, so it looks like we're pretty split between B and E, but most people still said E, and that's the answer. So this patient obviously has atrial fibrillation, and I gave you a bunch of reasons that their CHA2DS2-VASc would be, greater than 2 and would be indicated for NOAC. So we got that right. In terms of whether you should stop aspirin and then what the dose of the Eliquis will be. So the AFIRE trial and then the OAC alone trial, which included patients with the CHA2DS2-VASc of 4 or more. It was a class 1 indication for oral anticoagulation. But this trial also showed that there is increased bleeding and with the combination of oral anticoagulation as well as antiplatelet therapy with aspirin. So in patients, it's a class 1 indication that in patients with AFib and chronic coronary artery disease, so beyond 1 year after revascularization. So this patient, I think the CABG was a few years ago. Without history of stent thrombosis, you would just use anticoagulation as monotherapy and stop their aspirin. And then in terms of dose reduction, this patient met 2 out of the 3 criteria for dose reduction of Eliquis. So she was more than 80 years old and her creatinine was more than 1.5. So she would meet indication for a dose reduction. All right, next case. So you have a 72-year-old with a past medical history of treated pulmonary tuberculosis who presents with progressive dyspnea on exertion, lower extremity edema, and abdominal distension. And physical exam blood pressure is 110/80 and heart rate is 90 beats a minute. He has significant 3+ pitting edema to the thighs. JVD is elevated to the mandible. It increases with inspiration, and lungs are clear to auscultation. The liver is enlarged and there is noted ascites on exam. Echocardiogram reveals normal LVEF with mild concentric hypertrophy, normal RVSP, and severely elevated RA pressures with a dilated and non-collapsible IVC. There is no pericardial effusion. There's also a slight septal shift noted with inspiration. What is the diagnosis? Is it A, cardiac amyloidosis, B, restrictive cardiomyopathy, C, constrictive pericarditis, or D, pulmonary hypertension? All right, so looks like the polls are showing that most people chose C, which is the correct answer. So if you're just kind of thinking about test taking, you know, strategies, so cardiac amyloidosis and restrictive cardiomyopathy are not synonymous, but they're, cardiac amyloidosis is a type of restrictive cardiomyopathy. So I think it would be kind of hard to kind of pick one versus the other in that case. And then D, I specifically said that the patient's echo shows a normal RDSP, so that would exclude pulmonary hypertension. But really the key here is, when they give you details that are sort of non-cardiac history, like pulmonary tuberculosis, they're usually given for a reason. And so tuberculosis specifically puts patients at risk for having constrictive pericarditis. It's known to cause a lot of just calcifications around the pericardium. And so this patient is really kind of set up to look like a HFpEF patient, a patient with ascites, but the specific presentation that they have, pulmonary tuberculosis, is kind of what increases that this is constrictive pericarditis. And what you see basically is that the patient has what we call Kussmaul sign. So there's a paradoxical increase in the JVD with inspiration. So normally when you inspire, your RV fills and your JVD goes down. But when you have constrictive pericarditis, what happens is that your LV and your RV are both in this sac that they can't independently kind of relax of each other. And so when the RV tries to relax, it can't completely relax, and the RV can't kind of accept that blood because of that sac that's kind of constricting it. And so you get this increase in your JVD, which is not what should happen. That's pretty classic of Kussmaul sign. And then, all the other features of constrictive pericarditis clinically, which tend to be very often things that look almost like liver disease, with the ascites, lower extremity edema, et cetera, but in the absence of pulmonary hypertension. So risk factors, so patients with prior open heart surgery. So even if a patient just had a prior CABG, prior pericardial effusions, particularly if they've had like a complex effusion in the past, like a hemorrhagic effusion, a bloody effusion, et cetera, tuberculosis, and then chest radiation. So if patients have had, high doses of chest radiation for lung cancer, breast cancer. And the hemodynamic impact is basically that you have equalization of all pressures in all four heart chambers. Again, because all four heart chambers are encased in this sac, and they can't independently relax of each other. And that's why you get that interventricular independence or discordance, which causes that septal shift. Is that when the RV tries to relax, it causes pushing on the septum that pushes on the LV. And then when the LV tries to relax and accept blood, it pushes the septum to the right. And so that's kind of what that septal shift is. So the signs that you see are, as I outlined, is significant right-sided congestion, lower extremity edema, ascites, due to these really high right atrial pressures. Right, there is a lot of thunder going on. Okay, so case 8, and let's see, we have 15 minutes. So a 32-year-old female presents with progressive palpitations and 1 episode of syncope last week. Today, she again had very persistent palpitations and associated dizziness. Her vitals are notable for a heart rate of 151 beats a minute and a blood pressure of 110/75 beats per minute, millimeters mercury. Her physical exam reveals an irregular rhythm. And here's a current and prior ECG. So on the left, you have the old ECG, and on the right, you have the current ECG. So I'll give you guys a second to look at this before I go to the question. All right, so the question is, what is the next best step medication to administer? Is it A, IV adenosine, B, IV metoprolol, C, IV procainamide, or D, IV diltiazem? I can go back to the EKGs for a second and then go back to the question. All right, so it looks like most people said A, and then the second most common was C, which is the answer. So, what this ECG is showing you is a patient with WPW syndrome. You can see that they have a short PR interval and this delta wave, and that's why it gave you the old resting sinus rhythm ECG. And so in WPW, what happens essentially is the patient has this accessory pathway that can be anywhere in the heart, but often left lateral. And so what happens is if they have a beat that goes from, the sinus beat, it will go both down the AV node as it should, but it'll also go down this accessory pathway. So the AV node we know is a gatekeeping property that slows conduction. Your AV node cannot sort of conduct at very, very high heart rates. But the same is not true of the accessory pathway. The accessory pathway is sort of embryologically more primitive, so to speak, and it allows for very rapid conduction. And so the combination of both of the conduction going through both of these pathways results in this short PR interval, so very quick activation from the sinus beat to the LV being activated, and then this delta wave, which is basically that accelerated conduction, kind of the combination of the AV conduction and the accessory pathway conduction. So that's why you get that resting ECG with these two features. Now, what happens is sometimes in these patients, even in young patients, they have a propensity for having atrial fibrillation. So now they're not in sinus, but they're in atrial fibrillation. And atrial fibrillation is this disorganized rhythm where your atrial rate can go upwards of 500 beats a minute. In normal people, they would have the AV node that will have this gatekeeping properties slow the conduction. You still can have AFib with RVR, heart rates in the 150s, 160s, but it can't go like 250, right, or very high because of this gatekeeping property. But if you have an accessory pathway, it kind of opens up the floodgates, and these patients can go very fast. And so what happens is that if a patient goes into atrial fibrillation and they have an accessory pathway and you block the AV node with those AV nodal blocking agents, which were on the question, then all of that blood flow or all of that, conduction and electricity is going to go through the accessory pathway. And so you're going to really, really rapidly activate your ventricle, and then those patients can degenerate to VF. So that is why in this question, you do not want to give the patient any AV nodal blocking agents, which is adenosine, metoprolol, and diltiazem. Instead, you want to give an antiarrhythmic, which will hopefully just get them out of atrial fibrillation altogether, and that's procainamide. Alternatively, if this patient becomes unstable, most of the time what you would do is cardiovert this patient. Okay, sorry for so we still have 10 minutes, and I think I have two more cases. Do you think I should go through those cases or hold off for questions and breaks?
I think it'd be very reasonable to do another case.
Okay,
Um,
sounds good. Okay, so you have a 45-year-old female with a past medical history of hypertension who presents for shortness of breath. Cardiac exam reveals a diastolic rumble heard best at the apex, and there are crackles on lung exam. Transthoracic and transesophageal echocardiogram shows an EF of 60. The mitral valve is noted to be thickened with fusion of the commissure and without significant calcifications. Opening of the leaflet tips is restricted. The mean mitral gradient is 20 millimeters mercury, and the valve area is 1 centimeter squared. There is no significant regurgitation. What is the next best step in management? Is it A, refer for a mitral clip procedure? Is it B, refer for surgical valve replacement? Or is it C, refer for percutaneous balloon mitral commissurotomy? This was a pretty very close question on MixSAP. Very similar. All right, so looks like most people said C, which is the answer. So the key here, the diagnosis that we're looking at is rheumatic heart disease, and specifically rheumatic mitral stenosis, not mitral regurgitation. So a MitraClip is used for mitral regurgitation. So you would not want to do a MitraClip in mitral stenosis because you're just going to make that worse. In terms of surgical valve replacement, repair versus a mitral valve commissurotomy. So here's kind of the valve guidelines for rheumatic mitral stenosis. So in patients who have a pliable valve, so if the question instead had the patient has very significant calcifications or they have a lot of regurgitation, you wouldn't want to do a balloon valvuloplasty in these patients because what can sometimes happen if they're very calcified or they already have a lot of regurgitation, you crack that valve and you make the regurgitation even worse. So if they have a lot of calcifications, then mitral valve replacement or surgery is the better option. But if they have a pliable valve, they don't have any clots, and they have low level of mitral regurgitation, then balloon commissurotomy is the preferred choice. If, on the other hand, they have, let's see, severe symptoms, they're not surgical candidates, or yeah, if they have, sorry, if the valve is not pliable, there is significant mitral regurgitation and they have symptoms, then you would do a mitral valve surgery itself. Other indications for intervention for these patients, even if they're asymptomatic, if they have a significant amount of pulmonary hypertension. So again, that's sort of the downstream effect of mitral stenosis is pulmonary hypertension. So if they're already developing some of that, then you want to intervene sooner. Or if they develop new atrial fibrillation. These patients really don't tolerate atrial fibrillation very well. So even in sort of an asymptomatic patient, these would be sort of indications for intervention. All right. Let's see. One more case I think we potentially have time for. So we have a 45-year-old male who presents with fevers, chills, and progressive dyspnea. He has no significant past medical history. He, however, reports use of IV heroin several times a week. His vitals are notable for a temperature of 101.2, blood pressure of 100/45, and a heart rate of 45. Physical exam is notable for a short early diastolic decrescendo murmur heard best at the third intercostal space. There's also a rumbling diastolic murmur heard best at the apex near the fifth intercostal space. He has an elevated white blood cell count, and blood cultures are positive for MRSA. And his telestrip is shown below. What's the most likely valve pathology? Is A, rheumatic mitral stenosis with endocarditis? Is it B, endocarditis with mitral regurgitation? Is it C, endocarditis with aortic regurgitation? Or is it D, endocarditis with tricuspid regurgitation? All right, so it looks like most people got the answer right. Actually, no, sorry. Most people said D, but the answer is in fact C. So the key here is that number one, the patient is bradycardic. You know, this patient sounds septic, so it'd be kind of unusual for the patient to be bradycardic. And then when you look at the telestrip, you can see the patient is in complete heart block. So that is a specific kind of, a key part of the question. And then also the murmurs. So murmurs are always kind of there. So a diastolic decrescendo murmur is more going to be aortic regurgitation, right? And then that rumbling diastolic murmur, we can talk about what that is. But essentially, the complications of infective endocarditis is that certainly they can have cardiogenic shock due to low cardiac output, but in aortic valve involvement, can get regurgitation, aortic root abscess, but they're also very high risk for having complete heart block. So, and that's because the AV node is right here, and the aortic kind of annulus is right here. And so if you have any root abscess, edema, it can kind of press on that AV node and cause complete heart block. So anytime you see endocarditis with complete heart block, you should be thinking AV node, or sorry, aortic valve, and that's usually a surgical emergency. It's a class 1 indication for surgery. These patients without aortic valve valve involvement can also have coronary embolism. In terms of the murmurs, the diastolic murmur is the aortic regurgitation, but then you also can get what we call this Austin Flint murmur, is that the aortic regurgitation can basically press on this mitral valve and kind of cause a functional mitral stenosis. And so that was that diastolic rumble, the Austin Flint murmur. So here are just some other additional topics that I didn't cover. A fair amount of vascular stuff, PAD management, pericardial effusions, tamponade. Murmurs, again, are pretty heavily tested. So I think you should try to focus on, is it systolic, is it diastolic, and then where is it located? That will help you a lot. Prophylaxis for endocarditis, DAPT, ACS, triglycerides, GLP-1s, SVTs. These are kind of some other topics I didn't get to go through. I think that's all that I have. I don't see any questions in the chat, but let me know if there's any questions that come up. I know I went through this kind of fast. I wanted to kind of hit some harder topics, and so kind of intended for people to kind of not get them right. But that's, now's the time to make errors and learn. So
Thank you so much. That was fantastic, and really appreciate the pacing. We will also have a talk on valvular disease that'll cover some of the murmurs, because indeed, as you're saying, that is a highly tested area on the test, and then also for ischemic heart disease and ACS.